Cranial regulation neurologic disorder. In this chapter, we're going to talk a little bit about some of the anatomy and physiology, comparing children to adults. We're going to talk about some neurologic disease factors associated with kids. We're going to talk a little bit about some medications and treatment of conditions. We're going to look at a few of the risk factors with some of the problems. We're going to talk about some signs and symptoms of neurologic illness. We're going to talk about some interventions and then the psychosocial aspect. Okay, just a little review slide. So in the first 3 to 4 weeks of gestation, infections, traumas, teratogens or malnutrition can really cause some defects in the neurological system. So if you think about it, a lot of people don't know when they're 3 to 4 weeks pregnant, and so they may be engaging in some risk-taking activities at that point. A mother who's anorexic is not getting enough nutrition, therefore her baby will have some CNS developmental issues. At birth, the cranial bones are well developed, but they're not fused, so there's more of a risk for fracture with a fall. The brain is highly vascular, so any type of hemorrhage into the brain is going to cause some signs and symptoms. And then the spinal cord is mobile, so there's risk for cervical fractures. Just a couple of the antibiotics, or excuse me, the medications that we use for kids with neurological disorders. Of course, if it's an infection, we're going to use some antibiotics, anticonvulsants for seizure medications, some benzodiazepines. We use those, and there's a list of some of them. Analgesics. When you get into the more detailed neurological issues, we're going to talk about osmotic diuretics, and then we're going to talk you're going to be using those, and then some corticosteroids at that point also. So we're going to talk about epilepsy. With epilepsy, we think about a long-term disease. So it's a condition where seizures in the brain recur, and typically it's a history of seizures before they label it epilepsy. And the prognosis for seizures associated with epilepsy is good. There are a lot of new medications out there that treat seizures, and your book talks about that children will outgrow epilepsy, but some children will have persistent seizures. So again, sometimes it's a lot of adjusting different medications to fit the current symptoms. Kids who have a family history of epilepsy are more at risk or complications during that prenatal, perinatal, or postnatal periods, which Doris will go over a little bit in OB, and then changes in milestones or delays and fevers or illnesses. So types of seizures, we're going to talk about a few of the types of seizures that we see in kids. So infantile spasms, Doris may mention those in your OB lecture, and those are usually between 3 and 12 months of age. Obstinate seizures, or some people call them pedomal. Those are just the generalized seizures, not so much like the tonic-clonic that we think about. Tonic-clonic is the full body seizures. You can have just tonic or just clonic, or the tonic-clonic we used to call grand mal seizures, but now we've renamed those. So your book goes into some details on seizures. I'm sure you've heard them mentioned in second semester, so we're going to talk just a little bit about kids with seizures. We have febrile seizures. We'll go into those also. One of the biggest areas of concern for us is status epilepticus. So a status epilepticus, that's a time when the child is seizing and it doesn't stop. And we're concerned about brain damage at that point. So a little slide on Status epilepticus, continuous seizure for 5 to 10 minutes, over 5 to 10 minutes, and that could be different time periods in different books. And then, or 2 seizures without full recovery. For full recovery is not them going into the post-ictal period. It would be them going back to their pre-seizure state, whatever that may be. Because if you think about a kid with developmental delays, they're not going to go back fully functioning. They're going to go back to their pre-seizure state. With status epilepticus, you really want to stop that seizure. You want to, it's an emergency, it's a medical emergency. And so you want to start with your front line. And the 3 medications, that's a choice that the doctor makes. So either your lorazepam, diazepam, or midazolam. And we can give those IV. We can also give midazolam IV, IM. After we stop the seizure with those medications, we'll go ahead and start their anticonvulsant medications. We most often use avasfentoin, and then there's other things that we can use. And then 3rd line, this is if they don't stop seizing. You've given them all the 1st line drugs. You've started your 2nd line. And then the 3rd line would be either pentobarbital, which I've never ever seen used, but propofol we have. So you're going to put them into a state where they are paralyzed, and with propofol, so that seizure will stop. And then they'll do some investigation as to what's going on. A lot of times it's their seizure medications they've had at home are not appropriate for their weight now, things like that. And then, of course, always check your finger sticks with any type of illness. When we talk about neural tube defects, we talk a little bit about what's happening developmentally. I'm going to go back a slide. I want to talk about febrile seizures. Febrile seizures are not epilepsy, and it's really the most common thing we see in kids under 5. What's happening in a febrile seizure is not that their temperature is going, it doesn't go by how high the temperature is. It's that fast rise to a high temperature. So it's usually around 102.2 or 39 Celsius. And so it lasts about 15 minutes, and it'll occur maybe once or twice. And then usually parents seek medical attention. We will give medications for the fever, and typically that will be enough. If they continue to have seizures, there'll be more investigation into the seizures. It's very scary for parents. They need a lot of support at that point. And to let them know that a febrile seizure does not necessarily mean that they have epilepsy. Okay, now we'll go to neural tube defects. So in the development, in the first few weeks of the embryonic life, there again is potential for some developmental issues. So they can have neural tube defects, one of the ones that we see the most or hear about the most. We don't see it the most because we've decreased the rates of it, is spinal bifida. So spinal bifida is an opening into the spinal column. We've decreased the incidence of that for by giving the recommendation that all women of childbearing years take folic acid, not just all women who think they're going to get pregnant or all women that are pregnant. It's anybody of childbearing years should take folic acid. Let's go to the next slide. So this is a slide of the spinal bifida. So your normal spine is here. Your spina bifida, you don't really have to remember the 3 types, but this spinal bifida occulta would be just an opening into the bone, into the spinal column. It could be a hair tuft. It could be a dimple, is all we see. Nurses sometimes in the nursery may identify this. With a meningocele, it's just more of a bulging of fluid out, a little easier to see. And then with myelomeningocele, it's going to be bulging of the fluid and nerve. So this is obviously a worst case scenario. With spina bifida, if it's repaired, kids can live a normal life. If not, or if it is severe, they may have some paralysis. Encephaly is going to be a bulging of the skull, an opening in the skull and a bulging of the brain out. Anencephaly is no brain, which is incompatible with life. And then microcephaly is a very small brain, which would affect, they'll have some neurological symptoms at this point. The anencephaly, if you kind of remember back a few years, this was identified with pregnant women who got the Zika virus, were more at risk for this. Hydrocephalus is too much fluid on the brain, could be caused by a hypoxic event during surgery or during birth, during surgery. There can be some events if they have to have some type of surgery. So it's caused by some kind of underlying brain disorder. It can be congenital or acquired, like I said. And the prognosis on this depends really on the severity of it. They will have a shunt put in, which we talked a little bit about in the skills. So when you come to skills, I'll show you the doll that has the shunt in there. And the shunt drains the fluid into the stomach. And so that relieves the pressure on the brain, and they have a decreased in incidence of intracranial pressure. Craniocytosis is where the sutures fuse too early, and so that stunts brain growth. When they have a shunt in, so you can see the shunt, before the shunt, the ventricles are enlarged, and after the shunt goes into the ventricle, has a little port here, and then drains behind the ear, goes all the way into the stomach, and it will drain and be absorbed in the stomach, the fluid. So signs of a shunt infection, which would be some of the same signs of increased intracranial pressure. So your elevated vital signs, poor feeding in an infant, inconsolability, seizures, maybe some inflammation along the tract. So this is just a little slide on complications. So after a VP shunt has been surgically put in, they could have some temperature changes, we might want to think about meningitis. Nuchal pain is that you can't touch your chin to your chest without severe pain, and some of the things we would do for a shunt infection. Head trauma. We talk a little bit about head trauma when we are talking about pedestrian injuries. So kids who have been hit by a car. Remember I talked about how kids can see the car, so they think the car can see them. And so there are a lot of injuries there. It's right now the leading cause of morbidity and mortality is head trauma or any kind of trauma. So with head trauma, injury causes more death in children than disease in the United States. So that's pretty scary. So falls, again, when kids are smaller, they lead with their head, so they're going to fall. Your motor vehicle accidents, maybe they're not in the right car seat, in the car seat at all. And then the accidents, and then child abuse. So shaken baby syndrome, kids who are thrown against a wall, thrown on the floor, things like that. This little slide was kind of interesting that riders who wear a helmet have a 51% lower risk of severe TBI, so brain injury, and 45% lower risk of fatal injury, so helmets help. TBI is traumatic brain injury. It happens when there's some type of disruption in the brain from a fall, severe concussion, being shot, motor vehicle crashes, any type of problem to the brain. And again, the prognosis really depends on the injury. On page 1414, there's a table that talks about head injuries. So skull fractures, you need a lot of force to be able to cause a skull fracture. Um, then it talks about some of the types of fractures. So linear is obviously just a simple fracture. Depressed skull fracture is when we worry about the increased intracranial pressure because something is pushing now into the brain, the bone, and causing pressure. So you're going to see signs and symptoms. Compound would be more than one fracture. Your basilar skull fracture is going to be just that, some fractures in the base of the skull. You may see some rhinorrhea and otorrhea, so the fluid coming out the nose or the ears. You could have bleeding. Concussions, we see a lot of concussions with kids, sports injuries, falls. Concussion is an injury caused by some type of blow or jolt or shaking. Concussions, sometimes they can have loss of consciousness, confusion, amnesia. Treatment for a concussion is rest and monitoring. The biggest thing that you want to think about with a concussion is for sports, not letting them go right back into play. There are return to play protocols that need to be followed. It's the decision of when they go back in is really up to their pediatrician, not the trainer. And it's a gradual increase into play again. Every time you get hit in the head, you'll have worsening symptoms. A few years ago, there was a movie called Concussion, and the physician in the movie went up against the NFL because they were finding that NFL players, as they aged, would have so many different types of injuries or some illnesses. So something like dementia, they may get to the point where they will kill themselves, homicidal ideations, drugs, alcohol, because of those constant injuries to the brain. So it's an interesting movie when you have time to watch a movie. One of the Healthy People 2020 goals is to reduce fatal and non-fatal brain injuries. So really those bicycle helmets, the sport injuries like the return to play are part of that protocol. Non-accidental head trauma, so somebody is doing something to the kid. So violent shaking, that shaken baby syndrome, any type of blow to the head, when an intentional a kid hitting the wall with their head, furniture, the floor, any type of that, you're going to have some type of a head trauma. The shaken baby syndrome triad is retinal hemorrhaging, brain swelling, and then a subdural hematoma. So your hematomas, you have the subdural and the epidural hematomas. And when we think about that, we want to think about, that brain shock to the brain, also the signs and symptoms of increased intracranial pressure. If it was an infant, you may see if they're an infant and the fontanelle's open, you'll see bulging of the fontanelle. On your book in page 1415, it goes over subdural and epidural hematomas. The subdural hematoma is most commonly seen in kids. Again, those falls and things like that. And the epidural would be seen when their head trauma is very severe. The epidural is a bleeding of an artery. The subdural is a bleeding of a vein. So with the subdural, you may not see symptoms right away because it's going to be a slow bleed. And one of the examples I can give you in the adult world is a little old lady who falls and hits their head, and over the course of a few days, they get increasingly confused. So one of the things that they ask is, have they had any falls recently? With an epidural bleed, you'll see symptoms right away because it's an artery. Closed head injury. So closed head injury is nothing is going into the brain. So a fall, a motor vehicle accident, things like that. Typically, there's no loss of consciousness, things like that. And then drowning, because that's an unintentional death, because when they fall in the pool, they often hit their head. So they will have a head injury, and then and then they will take on water and not be able to come back up. Some of the states of consciousness we need to know about. So full consciousness, that's what you should be right now. Awake, alert, oriented. Confusion, maybe you're confused. So disorientation, alert, but just not answering questions properly. That's why we question people. Do you know where you're at? Do you know your name? Things like that. Attended is the child is limited response to the environment. They will be sleeping unless you will stimulate them. So this kind of, I like to compare it to maybe a person who's drunk. They're obtunded, they'll be stimulated, they will wake up, go back to sleep. A stupor is when they only respond to vigorous stimulation. So that rubbing the sternum area, painful, poking them with a pin, things like that. And then a coma is they can't be aroused at all. So family teaching, the biggest thing in this situations with head injuries or any type of neurological defect is assessing the family's willingness to learn, providing the time to adjust to the diagnosis. If this is a new onset seizure disorder, they're going to need time to adjust to what this is, what it's going to mean for them and their family. You need to repeat the information. If you're talking to a patient with a TBI, you need to constantly repeat the information. Gear it towards their level again, and then multiple ways to teach is important. And that's it.